actually been a great mentor to me. I don't know if Lee knows it, but he has mentored me as a role model and as opportunities throughout my career. And Lee developed a clinic at the NCI-NIH for this type of GIST called Pediatric wild type at the time, for which nobody really had any understanding. And Lee's work with his collaborators and the rest of us attending the clinic over 10 or 12 year period really shaped the understanding of this black box of an unknown type of GIST into a biologic understanding, clinical understanding of Sdh deficient GIST. And really, right now today, we're really poised at the brink for additional work, additional collaborations, and additional efforts will allow us to leverage that understanding into new treatments for patients with Sdh deficient GIST. And so it's with great, really great gratitude I thank Lee for coming and the work that he's done. And I'd like to introduce Lee to give us an overview of the clinic. Thanks, Lee.
So let me thank all of you, and I very rarely disagree with John, but I'll disagree with one thing. It's not because of me, it's because of all of you. You know, all of our patients that volunteered to come to the clinic, and all of our colleagues. So this was just and I wanted to start, I asked Norm to stay in the room for a little bit because he has to run next door. But this was really an amazing meeting we had, and this was 12 years ago. We were at ASCO, and I was frustrated because I got interested in seeing these children with GIST, but I would see one a year, and I'm like, you know, there's no way I'm going to learn anything. And on your left is Alberto Papo. He's another pediatric oncologist who is at St. Jude, and he said, yeah, I see like one a year, and Norm approached us and says, well, why don't we do something about this? And I forget, I think we were at a rare tumor session, Norm, and we said, let's have a clinic. And so we shook hands, and 2 years later we were seeing our first patient. So Norm, I appreciate everything you did just to say, don't complain about it, do something about it. And that's really, hopefully, the theme of this meeting. So thank you, Norm, and thank the Life Raft group. It was really an incredible, just an incredible meeting, and we were able to do something. And so the clinic was established in 2008, and you can see all of the collaborators, many institutes across the NIH and external, you can see listed here. And we even had people coming from as far as Australia and Ireland the first few years. So this has really been an international effort, and you'll hear more about that. We have colleagues just around the world now. Whoops, that goes the wrong way. I see it there. Okay, so I just want to talk quickly because I know Dr. Hernandez, who took over running the clinic when I left NIH and moved to Children's Hospital Los Angeles. But just a quick background of how we understood that we had a problem with childhood GIST and how different it was from the more common GIST, and then a little bit about management principles. Just quickly, most GISTs occur in either the stomach or the small bowel, and that's, do I have, let's see, well, it's all right, I don't have a point. Oh, I do have a point. So here's the stomach, and here's the small bowel. And that's where most of, you can see 90% of GISTs occur in that area. And it actually, I got it. When I started as a fellow in 1983, GIST didn't even exist. So it really just became an entity in 1983. And originally it was mostly treated by surgeons, and the oncologists, the medical oncologists, had really nothing to do with it, very little, and that's because chemotherapy didn't work at less than 5%. And what happened in rapid succession was a group in Japan identified that these tumors originate from the interstitial cells of the Hall, and then rapidly it was found that they had mutations, often in either KIT or PDGFR, and it turned out that imatinib that had changed the world in chronic myelogenous leukemia also inhibited KIT and PDGFR, and the rest was history. And I just showed this paper that was published, I think, in 2004, I believe, from our colleagues in Europe, but there was a simultaneous study using imatinib or Gleevec in both Europe and the US, and you can see just what an incredible impact this had on overall survival. We don't have this happen to us very often, although hopefully more and more these days, but this really changed our approach. And also, quickly we were able to identify guidelines when to, in patients, adult patients that were resected, when to treat them with adjuvant Gleevec. But it didn't work in our patients. When I kept seeing these children, I hadn't seen one kid over, I'd see 3 kids in 3 years and nobody responded. So I'm like, what's going on? This cannot be the same. It looked exactly the same or close to the same in the microscope. And this is a slide I took from my dear colleague, Dr. Mietnin, who's sitting right here in the back of the room. And what I just want to show here is if you look at the red, these are SDHB negative tumors, the red ones, and you can see that most of them in the younger age group are SDHB deficient, and as you get to about the age of 30 or 35, they're all SDH positive. So something about SDHB was really different, and it's really clustered in these young patients. So that was a hint. Oh boy, this doesn't show very well, but that's okay. This is again showing the distribution of GIST, and you can see that about 85, more than 86% of patients have either mutations in KIT or PDGF. We're talking about these SDH deficient tumors. It's 4%. So no wonder we only saw 1 or 2 patients, and that's when we realized we've got to work together. These are too rare, and that's really what made us focus on these patients, as we realized that we were really talking about a different disease. And we started the clinic, as I said, in 2008. And it was really a unique collaboration because we invited patients from all over. And I remember, I didn't know, the first clinic I thought, I don't know, we'll see 5 patients. And I think we saw 14 patients or so, the first. And it was an amazing, to me, the most amazing thing about the first clinic is that the 14 families and patients that came, every one of them thought they were the only person in the world that had this disease. And to see that others had the same disease was really a very powerful thing for us as doctors, but I think for the families and patients as well. But we brought in clinicians from around the country, support groups, patients, and what we really wanted to do is understand this to try to make progress in treatment, and we still have a long ways to go. And this is just showing that in rapid succession we were able to show that these were really SDH deficient. This is a paper showing what Sdh mutations do. It really changed the epigenetics of the genome. And this is Dr. Killian's work, who's sitting right here up in the front. We then published sort of our overall experience, and then our surgical colleagues. Is Mike here? I don't see Mike here. LaQuaglia and Chris Weldon sort of gave principles of treating this, how you treat this disease surgically, and it's really a different approach. So just a couple of quick comments, because I really want to keep us on schedule. About 3/4 of these patients have SDH mutations. Another quarter have what we call SDH epimutation or SDHC methylation. And this was work that came out of our clinic. And what was interesting is these SDH methylation, these epimutant patients, are younger. The median age is 15. And this is a slide I borrowed from Katie Janeway. And you can see they're overwhelmingly female. We've only had 1 male with an SDHC epimutant so far. And you can see that that the Sdh mutation tumors, a little bit older, median age of 23, and they're roughly 60% female, 40% male. So it's a slightly different subtype. This is just to show you, here's a KIT mutant tumor, and this is staining for SDHB, which we learned is the way to really identify these. You can see the dark means it expresses SDHB, and these are the Sdh mutant GIST, and you see no expression. This little bit of dark is in the normal cells, so it's not subtle. And the other thing, which you really can't see, but these squiggly lines show other mutations that we see in the adult GIST, whereas in the pediatric GIST or the Sdh deficient GIST, the genome's pretty quiet. It looks normal. And this is work from that Keith did on our tumors. These are the SDHB negative or the Sdh deficient GIST. And you can see this is looking at methylation. So the red means the genome is methylated. It's not a subtle difference. These are really different genetically. That's the point I want to make. And we now know that the consequences of not having SDH is you alter methylation by virtue of changing this enzyme. Doesn't matter. It's just an enzyme that's involved in demethylating the genome. You also affect this second enzyme called PHD that leads the tumors to think they're hypoxic, even though they aren't, and that may be something we can exploit therapeutically. Something that we really haven't explored is it also affects a demethylation of histones, which are the proteins that pack and structure the chromosomes. So we found mutations in all four SDH, A, B, C, and D, but we can still identify all of them just by staining for SDHB. I don't have to go into the details, but we know that works. And silencing, as I mentioned, using by this epi mutation. And this matters, and you'll hear from Konstantin Stratakis, who's been at this. And Konstantin taught us about SDHB mutations in a syndrome named after him, but hopefully he'll talk more about what the difference is. I'm more confused than ever. But we know there are distinct ways of either whether you have a mutation or an epi mutation. And the reason that's important is, one, for screening for the paragangliomas, and also, and you'll hear more about that also from Dr. Patrick, but also for genetic counseling. So just quickly, in the last couple minutes, as I said, the best screen is just doing immunohistochemistry for SDHB. And I have to say, at our last clinic, we just had a clinic in June. And one of the things I'm still disappointed is I thought we were disseminating this information, and there are still major medical institutions that don't understand this. They don't understand that if they see a patient that doesn't have a KIT mutation, they just need to do an SDHB immunohistochemistry. So we need to do a better job disseminating this information. These tumors are almost always in the stomach. I think we've only seen one bona fide Sdh deficient that's in the small bowel. But I don't know, there may be others around, but they're very rare. None of them respond to imatinib, but we have seen responses to sunitinib and regorafenib. I think that's likely due to their effects on VEGF, but not 100% clear. And the other thing that's so important is that most SDH mutations are germline. Why is that important? Because that means if you're a 20-year-old and you're going to grow up and have children, you need to know and have your children tested, or at least we would recommend that, because they could inherit that mutation. And lastly, the important thing I want to show from our surgical colleagues, Dr. Weldon and Dr. LaQuaglia, is that for patients that don't have detectable metastatic disease, what they were able to show in about 86 patients is if you do a radical complete resection, it doesn't matter. It doesn't improve event-free survival, but patients survive. So you can get a recurrence, but so doing a radical surgical procedure is not recommended. What you want to do is do the procedure that's not going to have a major impact, but affect the symptoms that you're doing the surgery for. And I just, one other thing is, and we're not going to talk about this today, there's also an NF, or neurofibromatosis 1 associated GIST. that we really know very little about. And you're going to hear about these other issues. So from my perspective, the future directions are we want to continue to see patients, learn more. Every clinic we learn more. We've been hampered by our inability to get cell lines that have these mutations. Jason, where are you? Dr. Siklik, we hear, and I can't wait to see his data. He's been working hard, and he thinks, I think we have now some cell lines that are Sdh deficient, which is huge because it will allow us to do drug testing and combination drug testing. So we haven't been able to do that.
Can you explain what you mean by cell lines?
So these are, so those are just cells that are Sdh deficient that we can grow in plastic. So then we can do experiments on them. So without
it's like families donating tissue, that kind of thing.
and we have tried for really since we started the clinic to get tumors. They're directly from patients. We mince them up and we try to get them to grow because then they're renewable and there are ways. Hey, we can test them. And so I'm really anxious, and we're going to talk about this this afternoon, and we're really anxious to see this data. We need, and I just want to say, because of the hypermethylation, there are drugs that demethylate the genome, and we're hoping that those may contribute and help with the treatment. We just opened, or not about a year ago, opened a study at the NIH using a very potent demethylation agent or DNA methyltransferase inhibitor called guadicitabine. But I believe, and I think most of us believe, we're going to need combinations, and that's why having cell lines to test these in are so important, so that we can move forward in a rational, based on rational data. And we still want to develop prognostic markers because we can't really know. Well, the way we like to treat patients is what I'd like to do is treat them right before they get symptoms if I had something to do, and leave them alone. Most of the time you just live your life and feel well because it's a very indolent disease in general. So we're thinking about trying to do circulating DNA. And I just want to end, and this is a patient of Katie Janeway's. Is Katie here yet? Let's see Katie. But I got permission to show this slide. I emailed her the other day. So I don't have to say it. You can read this quote, and it really means a lot to all of us. So thank you.
Jennifer and Elisa are here.
Yeah, I know. Jennifer, you want to stand up?
No.
Anyway, thank you. Because it really, I didn't want to embarrass her, but it means so much to us. I mean, we really appreciate it. We work hard. And this has been it really is a collaboration between families and patients. So thank you guys very much.